extensively. So because these are things which are asked in exams. Okay. There's a pool of CCT questions from which we put the questions. I think all of it has been covered. Thank you, Cam.
Now, I would like to introduce the next speaker of this session, Dr. Deepak Dhirubhai Valia. Sir has completed his MBBS at MP Shah Government Medical College and MD at Guru Gobind Singh General Hospital, Jamnagar, Gujarat. Sir worked in critical care unit at dedicated COVID-19 at GG Hospital, Jamnagar, Gujarat. Sir currently is pursuing his DNB cardiology at Triple IHMS, Whitefield, Bangalore. I welcome you, sir.
Chamber and okay. Good afternoon to everyone and Sairam to everyone. Yes. Today I am presenting a chamber enlargement in the ECG. So Yamini already told the normal P wave amplitude and all the PR interval TP segment, all are the normal value are the talked by the Yamini. And now I am what is the changes during the enlargement of the heart and what is the changes in the ECG during the enlargement. I am talking about this segment. So there are the four chamber in the heart: right atrium, right ventricle, left atrium, and left ventricle. So the first I will describe the right atrial enlargement. When there is a right atrial enlargement, the changes in the ECG, the total peak P wave in the lead 2 is more than 2.5. Okay, so there is a one. There is a 2.5. There is a lead to there is more than 2.5 total peak P wave, and P wave in the V1 amplitude is more than 1.5, and the rightward shifting of the P wave axis more than 75 is described with the right atrial enlargement, and most probably these are the seen in the pulmonary disease, and so most is called P pulmonary. Then the QRS criteria for the right atrial enlargement, the QR pattern in the lead V1 in the absence of the cardiac disease and CAD, and in the QRS amplitude in the V1 is less than 5 millimeter, and QRS amplitude V2 is more than 3 times than QRS in the V1 is a criteria for the right atrial enlargement in the QRS. So the right atrial enlargement sensitivity is very low, but specific very high, 96 to 100%, and is given by the in the Brunwald heart disease. And this is the right atrial enlargement with the P pulmonary. Just there is a seen in the T wave more than 2.5 millimeter in the 2-3 AVF, and this is a P pulmonary, and this is suggestive of the right atrial enlargement. So there is a severe PS with a pseudo P mitral, P in the lead V1. There is a entirely negative in the P1. This is called pseudo mitral because of there is no MS, but severe because of the severe PS there is a P wave is a increase in the amplitude more than 2.5. So the in the sometime RAE and LA both having the V1 may be negative. So how to differentiate between the LA and the RAE? So distance between the peak wave and the P nidus. Okay, so this is the P peak and this one is the P nidus. So difference between the two, this distance. Okay, if it's less than 0.03 millisecond, then it is a right atrial enlargement. And this is a different distance is between more than 0.03, then it is a left atrial enlargement. So this is the Himalayan P wave in which the P wave height is more than 5 millimeters. Okay, so this is the Himalayan P wave and yes, yes. Very classic sign of this. Is already in next slide. Yeah, answer is already in next slide. So can yes. So there is a giant P wave F10 anomaly is seen in the F10 anomaly, and sometime in tricuspid atresia and both tricuspid and pulmonary stenosis. This is seen in the Himalayan P wave. Okay. So the next topic is the left atrial enlargement. There is a wide wide-field P wave. Duration is more than 120 millisecond. By this duration between the between the two peak of the P wave, there is a duration is more than 120 second in lead 2, and the prominent notching of the P wave, and between two notch the distance is more than 0.40 millisecond is a left atrial enlargement, and it look like a camel hump. So it's also like a camel hump, left atrial enlargement. And the left atrial enlargement, other sign are the Macruz index and the Morris index. This is the classic sign in which the ratio of the P wave upon PR segment is more than more than or equal to 1.6, and if P interval terminal force in the lead V1 is more than 0.04 millisecond is a Morris index, Morris criteria. So there is a sensitivity of around 100% in cases of the notching interval between two notching is 0.40 second, and highest sensitivity in the Morris index. So the how to diagnosis is the left atrial enlargement in the patient with the AF. So the in RHD, all the patient having a presence with AF itself suggestive of the left atrial enlargement, and the course AF fibrillatory wave is more than 1 millimeter in the V1 may be suggestive of the LA in the RHD. So the AF is a coarse fibrillatory wave in the V1 is more common in the RHD, and the fine fibrillatory wave is there, then less than 1 mm, then there is maybe hypertension or the CAD. So the if you are taking the LAE and fibrillatory wave, 100 patient after the disease or conversion. So the coarse fibrillatory wave associated with the abnormal P terminal force in the V1 means there is a if there is a coarse fibrillatory wave is there, then most probably is the RHD, and after conversion of the T, there is a LA abnormality is present. And if there is a fine fibrillatory wave, and after DC convert to the normal rhythm, after the DC cardiac shock, so there is a less chances of the P abnormality because of there is no left atrial enlargement. So the biatrial enlargement is the feature suggested of the both R and LE, and the large biphasic P in the V1 and the tall and broad P wave in the late 2, 3 and AVF. So now atrial enlargement is over, and now I'm starting the RVH. So right ventricular hypertrophy, R wave in the V1 is more than 0.47 millivolt, and the QR in the V1 and RS ratio in the V1 is more than 1 with R in 0.5 milliwatt. So the R ratio of less than 1 in the V5 and V6, and the S wave in the V5 or V6 is more than 0.7 milliwatt. And right axis deviation is there more than 90 second, and S1Q3 pattern, S123 S3 pattern also may be seen in the sometime in the chronic pulmonary embolism patient. So the RVH is sensitivity is very low, and in the pH, in presence of the pH is up to 74%. So the accuracy is greater in the congenital heart disease and the lowest in the COPD. RVH with a pressure overload, there is a upright R wave in the V1, and associated with the S depression in the V1, V2, V3. So is a classical scene in the PS, and how to calculate RVSP according to this is the height of the R wave is height of the R wave. A small box is multiplied by 5 is give rise to the RVSP. So the RVH with the volume overload, in which the presence of the precordial R wave in the precordial lead is more than 10 mm in the incomplete RVB, and more than 50 mm in the complete RVB is suggestive of the RVH volume overload. So the type of the RVH is one is a pressure overload, second is the incomplete RVB or the volume overload, and third one is the associated with COPD. So the other causes of the toll are in the bleed V1 are the maybe seen in the posterior wall of myocardial infarction, right bundle block, or the wall Parkinson White syndrome. There are the muscle dystrophy and other. So the next is the LVH is most important criteria with the Sokolov-Lyon criteria, in which the S in the V1. Okay, so this is the S in the V1, and R in the V5 or V6 is more than 35 is suggestive of the LVH. And the R in the AVL is more than 11 mm. And the coronal voltage criteria is also S in the V3 plus R in the AVL is more than 28 mm in the men, and the more than 20 mm in the woman is suggestive of the LVH. And the some Romhit Ester point score system is also there. So the total number is 13, and the definitive LVH is if 5 or more point is there, and probably is if 4 or less. So this is the classic example of the LVH in which all the criteria are met. So the sensitivity against less, but specificity is high, 89 to 99%. And the LVH in the systolic overload pattern. Now the LVH in the systolic and diastolic. Okay. So the systolic overload, there is the absence of the Q wave and the ST depression, left precordial lead and the T inversion. And in diastolic, there is the presence of the Q wave, concave upward ST precordial lead and the upright tall T wave. So this is the LVH with the pressure overload, in which you are seeing the prolonged ventricular activation time and the transition zone in the V2 to V3 and the loss of the Q wave in the V5 and V6 and the presence of the loss of the Q wave and the presence of the ST depressions or the STT changes in the 5 and 6 and 1 and AVL is a pressure overload and is mostly seen in the hypertensive patient and the AS patient. So the LVH with the diastolic overload. In this patient, when the deep and the narrow Q wave in the lead V5 and V6, there is a deep Q in 5 and 6 is a suggestive of the volume overload sign and is mostly seen in the AR patient. So the T inversion in the LVH versus IHD. So already described the Dr. Gyan. There is asymmetrical T inversion and the blunt. In the LV strain pattern, there is asymmetrical, but not and blunt and not very deep. And in the ischemic, there is a symmetrical, pointed, and very deep T inversion in ischemic heart disease. So the LVH with LVBB, the Sokolow criteria is the less reliable. So the R in the AVL is more than 11. And S in the V2 plus R in the V6 is more than 45 and QRS duration is more than 160. Associated with the LA in LAD is also a diagnosis of the LVH with LVBB. So the LVH with the RBBB is usually precordial lead criteria and lower sensitivity is limb lead criteria is less affected and associated with the LA in LAD. So the LVH other important point are the maybe diagnosed in the single lead criteria by the R in the AVL is more than 11 and the R in the V5 and the V6. Normally there is R in the V5 is taller than the R in the V6. But in the LVH, R in the V6 is more than or equal to R in the V5 suggestive of the LVH. So biventricular hypertrophy specific criteria for the both the LVH and RVH and LVH with the RAD or the Kertzwirchel phenomenon. Is seen biventricular hypertrophy and the tall R in the right and the left precordial lead, LVH with the persistent SF in the V5 and V6. So this is the example of the Kertzwirchel phenomenon in which the large epicardial QRS complex might precordial. There is a R plus S duration is more than 45 in the adult or the R plus S in V2 or V3 is more than 45 in the adult or more than 60 in the children is suggestive of the biventricular failure or biventricular hypertrophy. Sorry, these are mostly seen in the PDA patient. So thank you all.
Thank you, Deepak. It was an excellent talk. Very quickly done, very nice. Again, just to reprise, I think he's covered most of the talks, I mean, most of the subjects which are asked. The first thing that is usually asked is, when you have an ECG in your hand, how do you know your ECG is right or wrong? Look at the P wave. P wave in one, if it is inverted, that means either it's a technical electrocardia or something wrong. Then all of this works. Anyway, does anybody know any of the newer criteria for LVH? This was asked last year. He spoke about Cornell, spoke about Rommel testis, and spoke about Sokolow line. Tell me a fourth one. Modified. No, that's there. What is modified Cornell? R in AVL more than 12. That's it. Okay. Then what is Peguro-Lopresti criteria? There's a newer criteria called Peguro-Lopresti. Anybody? Peguro-Lopresti. It's basically the deepest S in any lead and S in V4. You combine that more than 2.8 in males, 2.3 in females. Okay. Peguro-Lopresti came in 2019. It might be there in the newer Chow. It's there in Narasimhan sir's book. In any case, that is one. Then you are asked about PV abnormalities, which he has covered very well. AF, he was on saying that AF has no, I mean, if you see AF in RHD, it is LAE, right? Does AF in RHD have a relation with mitral valve area? More severe MS, more severe AF? No. AF has nothing to do with the mitral valve area severity. AF can come earlier as well because AF can either be because of the substrate or because of the valve. So if there is a substrate involvement, you have McCallum's patch, you need not get AF only in severe MS. It has nothing to do with the severity of MS. It changes the patient's life course. That's different. Anticoagulation comes in, AF ablation comes in maybe, but then it has nothing to do with the severity of MS. That's something which was also alluded to. Ma'am, anything else you feel Ma'am is there. I think most of the questions which is done have been covered. LVH criteria have been asked, repeatedly asked, both in practicals and in theory. I think is covered RVH. Like one question which Barua sir every time asks us and our DN residents. If you had to pick one criteria for RVH, looking at the ECG, which correlates very well on MRI, he spoke about 4 of them. Any one criteria, which would that be? More specific. Anybody? R in V6 more than 7 mm, 0.7 millivolts. If R in V6 is more than 7 mm, it correlates with the severity even in MRI. Sorry, not R. S in V6 depth more than 7 mm. It correlates almost 97% on an MRI based RVH. Okay. So anything else, sir? Anything else? I think most of the things have been covered. Gyan comes back for AV blocks.